Good morning. I'm going to talk to you briefly about interventions in acute stroke. And I'm going to take a liberty because I'm going to talk to you about some intracranial atherosclerosis during this presentation. When we talk about stroke, it's important to remember that Hippocrates actually recognized stroke almost 2,500 years ago. And this was described as apoplexy, or a patient being struck down by violence because of the sudden paralysis and abnormal behavior of the patients. And really little is known about the anatomy or the cause during that time. And the treatment was basically sending patients to a spa, and similar to what the treatment is nowadays, believe it or not. If we look at stroke, we can define strokes as both hemorrhagic and ischemic. I think most of you have seen these slides before. Fortunately, most of the strokes that we deal with are the ones that we try to intervene in are patients that have ischemic strokes, over 80% of the patients, with a small percentage of patients having the more devastating hemorrhagic stroke. Now, to talk briefly about intracranial atherosclerosis, why this is important, 8 to 10% of ischemic strokes are due to intracranial atherosclerosis. And the recurrent stroke risk in this, or actual recurrent stroke incidence in this patient population is very high, 15% per year. Intracranial atherosclerosis accounts for about 40 to 60,000 strokes in the U.S. every year. And the risk factors are actually kind of interesting because race and ethnicity increase the risk of having intracranial stenosis, more common in Afro-Americans and American Native Indians. Diabetes, cholesterol, smoking, sort of the usual offenders for atherosclerosis. As far as the prevalence is concerned, in this study where they looked at 4,700 cerebral angiograms, you can see the distribution of intracranial stenosis of about 22%. And when we look at the most common locations, we can see that the most common site is actually in this basilar region. And why this is important, because if you have a stroke that's going to be a fatal stroke, that's not a hemorrhagic stroke, then this is the area where your stroke will attack you and will more likely than not result in a fatality. If these patients are symptomatic and have intracranial atherosclerosis, they have a very high 2-year risk of stroke, as you can see here. Now, the treatment of asymptomatic stenosis is questionable because there's poor understanding of the natural history. There's not as much warning as far as symptomatic patients with TIAs, and there's no good alternatives. 5-year mortality with this disease is actually quite interesting when you look at it, because its 5-year mortality is worse than colon cancer. The intracranial vessels are interesting because they're similar to coronary vessels in size. Plaque rupture is not the most common cause or mechanism for stroke, and that's the same thing that we see in the internal carotid. Hypoperfusion, embolization are more common. It's important to remember that the arterial structure is different in the intracranial circulation, and this will be an important factor when you think about what we do in acute stroke intervention. So some practical hints. You want to restore adequate cerebral blood flow. You don't want to restore lumen diameter to completely being normal. So this is not coronary angioplasty where you try to attempt to achieve the most gain with that index procedure. The procedure results with intracranial intervention and with acute stroke intervention would be a suboptimal coronary intervention result. And you deliberately undersize balloons and stents. Intracranial intervention was first reported in the 1980s, but had high complication rates. If you can remember what the technology was back in those days. And those patients were at risk for dissection, thrombosis, again, recoil, and perforator stroke, meaning these small perforating vessels that abut the area that's stenosed are occluded with a balloon inflation or stent implant. And then there's also the risk of vessel rupture. And when we talk about vessel rupture intracranially, then we're usually talking about a fatality. So the goals of stroke therapy, most acute stroke victims should receive stroke reversal treatment. Okay, so most patients should have an attempt at stroke reversal. They should also have prevention for the recurrent stroke, and rehabilitation. And as far as stroke intervention, you want to decrease their future stroke risk. You want to limit the disability of that stroke. You want to control the blood pressure. Patients should not be extremely hypertensive. By the same token, patients should not be hypotensive. You want to treat hyperglycemia, something that commonly gets overlooked is the patient with an acute stroke who's hyperglycemic. You know, in my institution, or if it's my patient, then I will place that patient on an insulin drip because it's very important that hyperglycemia be controlled. Hyperglycemia causes more brain injury. Control of the temperature, patients shouldn't be hyperpyrexic. But we do have some data with intentional hypothermia that patients do have a beneficial effect. And basically you want to protect the penumbra, or that portion of the brain that's ischemic but hasn't decided whether or not to live or die. Safely restoring brain perfusion as quickly as possible is the ultimate goal, and that can be performed with IV thrombolysis, intra-arterial thrombolysis, clot retrieval or disruption, balloon angioplasty, stenting, where the stent is actually left in or whether the stent is used to remove the thrombus, and other investigational devices and drugs. IV thrombolysis, only about 2 to 4% of patients that have a stroke receive IV thrombolysis, even though this is an FDA-approved treatment. And 97% of patients that have a stroke get no therapy at all. A lot of times that's because the patients arrive to the hospital after that 3-hour window of opportunity to receive IV thrombolysis. But we do know that early intervention can potentially limit the devastating effects of a stroke. There's a window of opportunity, and that window of opportunity is narrow. Treatment should be analogous to what we do for acute myocardial infarction, implying that there's a door-to-balloon time or a door-to-brain time to treat these patients. But you need a multidisciplinary approach to treat these patients. And the reality is that there are too few interventionalists to perform these procedures. So endovascular therapy, advances in equipment, expertise, a broader range of areas to be treated, more interest in training and performing these procedures, and more specialists and specialties being involved have led to more acute stroke intervention. But stroke revascularization is just not simply a technical procedure. Their clinical success depends on a number of factors, and those factors include patient selection, how severe the stroke is, the onset of the stroke, age, as I mentioned before, glucose, blood pressure, where the stroke is and how much brain is affected, the volume of the brain at risk, the clot volume, and the status of the collaterals. At our institution, this is one of our studies, or this is a reference indicating that there is a need for stroke therapy and that the current state of the art is not sufficient. Stroke intervention, there are too few neuroradiologists, too few trained neurologists, and there are too few trained radiologists to actually take care of these patients. There are too few trained cardiologists also, but the potential for interventional cardiology exceeds the other specialties. Cardiologists have the technical skills and knowledge of endovascular equipment. That's only part of it. Additionally, we have knowledge of neurologic and general medicine. We work in collaboration with other specialties to take care of very sick patients. And we don't simply do procedures. We actually follow guidelines in evidence-based medicine, and we're accustomed to data collection and outcomes audits. I think the other portion, or other part of it, is that there are more than 8,000 active interventional cardiologists in the U.S. as opposed to a couple of hundred neuroradiologists in the U.S. And the number of active neuroradiologists is deceiving because all of these neuroradiologists aren't involved with acute stroke intervention. Just to quickly go through one of the references from our institution, this is the demographics of the 33 patients that we treated with endovascular techniques. And this is a table that summarizes the devices that we use. And you can see that the Mercy or clot retrieval device, balloon stenting, intra-arterial thrombolysis, or 2B3A inhibitors, and combinations thereof. These are the complications. These are the outcomes. And you can see when we compare this to the very limited literature that exists in treating patients with catheter-based therapies, that certainly this group of interventional cardiologists had results that were similar to previously published studies. I wanted to show you one representative case. This is a case of the middle cerebral artery infarct. You can see that the MCA is occluded using digital subtraction to identify where the occlusion is. And then this was done with simple angiography because of the patient moving. But you can see that this is crossed with a wire. Balloon angioplasty is performed. The nitroglycerin was given because of the spasm at the tip of the guiding catheter. And then after gentle balloon inflations with an undersized balloon, you can see the results. And you can see that this is certainly not a coronary-like result, but this is a result that's satisfactory for a patient with an acute stroke, and no stent was placed in this patient. In conclusion, in selected patients, catheter-based therapy provided by qualified interventional cardiologists, and that should be qualified interventionalists, period, supported by stroke neurologists, offers a safe, alternative, and effective option for patients with acute stroke who are not eligible for intravenous thrombolysis. Thank you very much.
If you have a patient with a massive stroke coming to us within, let's say, 2 hours, how should we approach such a patient?
Yeah, so that's a good question, and part of what I didn't want to do was give you a lot of just technique and show you balloons and stents going into cerebral arteries or into carotid arteries, because I think that undermines the whole concept of acute stroke intervention or a stroke service. Those patients that come in with an acute stroke, whether it's a massive stroke or not, need to have a neurologic evaluation and need to have a CAT scan, performed in the emergency department before any other intervention is undertaken. So those patients get stratified based on the presentation and based on what the results of the CT scan are, because clearly a patient that comes in with what looks to be an acute stroke or a large stroke sometimes has metastatic cancer, or sometimes has a bleed, or sometimes has an infectious process going on. And so you can't not anticipate that you may be fooled sometime.
Suppose the MRI or CT shows a large stroke, and how would you approach? Would you give intra-arterial, or would you do a intervention on such?
So if they come in, like you said, within 2 hours with a large stroke, they would receive intravenous thrombolysis if there's no contraindication. Now, the caveat to that is sometimes on the CAT scan, you'll see evidence that there's an occlusion at the terminus of the internal carotid, what we call a T occlusion. So both the anterior and middle cerebral artery are occluded. If you see that sign, those patients are less likely to respond to intravenous thrombolysis. And so the option is either give them intravenous thrombolysis with the understanding that after 30 minutes, if their symptoms haven't resolved, they'll go for a catheter-based therapy.
So preferably in your center, you're doing a CT-based protocol where you do a angio also in all patients with acute stroke. There are some centers which propose MR-based protocols for acute stroke presentation. So you feel that the CT-based protocol is better for diagnosis in these patients?
Yeah, I think it's like anything else. It depends on what your center is good at. If your center can do a good or interpretable MR, then I think that's fine. If you have a CT, then I think that's fine. If you have CT angiography. In our institution, we do CT with CTA and CT perfusion in the emergency department. So we can actually get a stroke patient from the door in the ED, seen by neurology, having their imaging study, and into the cath lab probably quicker than we can at acute MI. So probably less than 30 minutes we can do all of that.
Thank you very much, Mr. Chairman, and thank you, Dr. Collins, for being here with us.